Good evening, all the aspirants present here. Today we are going to have the Cardiology Class 2, and the speaker we have here is Varun Pushkarna. So you may start.
Today we will be covering two topics, very important ones: ischemic heart disease and hypertension. So basically, ischemic heart disease is and hypertension, both of them, they make the backbone of whole of the cardiology. Even if an examiner thinks of putting some questions which are with respect to the latest guidelines, the ones that are important, again they will be coronary artery disease and hypertension. Okay, so let's just take the view of it. So basically, ischemic heart disease is defined as an insufficient blood supply to the myocardium due to coronary artery disease leading to supply demand mismatch. Now, it is identified as a spectrum of a disease. So we have on one end of the spectrum stable angina, in which basically what happens is that the patient has a chest pain which is brought upon by exercise or emotional stress or anything that causes tachycardia or increase in the force of contraction of the heart. So both of these things, increase in the contractility or increase in the heart rate, both of them, they increase the oxygen demand, and when the coronaries are unable to meet that, there will be angina. Angina is the left precordial chest pain. So patient will give you the history that the chest pain comes with exertion and it settles with resting. That means it is a chronic stable angina. For example, if the patient says that I have chest pain, it used to settle with rest, but now it is persisting. Now that means it has got converted into an unstable angina. So acute coronary syndrome is another end of the spectrum, which is classified into unstable angina. That means unstable angina means stable angina gone worse. So the same way I told that patient when feels that I sit down, I feel better. But now, even after resting, the chest pain is still there, and there is no evidence of myocardial necrosis. It is still the blood is flowing. There is no 100% ischemia. There is no total occlusion, but there is a decrease in the blood supply. Hence, the chest pain goes for a longer period of time. That is unstable angina. Now, if the occlusion has occurred and it has caused a necrosis of the myocardium, that is known as ST elevation MI STEMI, where there is a transmural necrosis. ST elevation is seen in the ECG. We will look and try to understand which leads are important for those to demarcate the territory involved. Then is non-ST elevation MI, non-STEMI, where there is necrosis, but not full thickness necrosis. There is subendocardial necrosis. So starting from the outwards, it is pericardium and epicardium, myocardium, endocardium, and then the cavity of the ventricle. Starting from the inside, we have what? The cavity of the ventricle, then endocardium, myocardium, and then epicardium. So basically, subendocardial necrosis, there will be elevated troponin. Why? Because there is some necrosis. When the muscle damage occurs, troponins will be released. Unstable angina and non-STEMI, they are differentiated on this aspect that if the troponins are elevated, it is non-STEMI. If they are not elevated, then it is unstable angina. Okay. What is the pathophysiology? Usually, it's a plaque. It's a plaque which is a stable plaque. So a stable plaque causing hindrance to the blood flow. This is the main pathology for angina or a beginning of ischemic heart disease. Imagine this plaque goes on to increase in size, and one fine day it chips off. It chips off, making something look like this. So it has chipped off from this, and this chip has gone and stuck somewhere here. The chip that moved from here, it has got stuck somewhere here. This is called plaque rupture. So the plaque rupture leads to sudden occlusion of the distal blood vessels, and this is the basic etiology of acute myocardial infarction. So it is acute in process. The vascular territories, like we see the heart. So this is the RCA. This is the coronary sinuses. This is left circumflex. This is the left main. This is the left circumflex, and this is the LAD territory. So this is the LAD, this is the RCA. Then there are some branches like PDA is there. So and PDA, the origin of PDA also defines the dominance of the blood vessel. So we have LAD, which supplies the anterior wall and the septum, the right coronary, which supplies the inferior wall and the right ventricle, left circumflex, which provides the lateral wall, and posterior descending artery, PDA. So it supplies the posterior wall, and it can, this blood vessel is used to define the dominance of coronary arteries. Some are right dominant, some are left dominant, some are co-dominant. So that means the posterior descending artery originates from right coronary artery in right dominant vessel, in left anterior descending artery in a left dominant circulation, and from both the major arteries in co-dominant circulation. Is that clear up to now? So coronary artery disease diagnosis is based on presentation of the patient. So number one is clinical presentation. So what chief complaints patient presents with? So usually the chest pain is the main symptom, which is classically retrosternal, and it can radiate to the left arm or to the both jaws. Okay. Associated symptoms can be dyspnea, diaphoresis, and nausea. As far as once the patient has symptoms, the next step to do is get an ECG. So what will you see in ECG? In stable angina, you will either see a normal ECG, or there might be some transient ST depression if you have done ECG in time, or putting the patient on a treadmill test may lead to T wave inversion or ST depression on the stress test. Non-STEMI and unstable angina, you will definitely find ST depression and T wave inversion. The in STEMI, you will find ST elevation. So it will be there, convex or tombstone shape in vascular territories. And of course, reciprocal changes will be seen in ST depression in opposing leads. Now the patient started with chest pain, which was typical retrosternal associated with radiation to jaw or arm and diaphoresis. We did an ECG. We found out ST either depression or elevation or normal. So normal is stable angina, depression is unstable angina, or you can say non-STEMI, and elevation is elevation MI. So what next? You will do biomarkers, blood markers. So troponin I. So what will happen is, if the ECG there is ST depression, but trops are elevated, then it is non-STEMI. If the trops are normal, it is unstable angina. As far as, so we started from chest pain, then it was typical. We did an ECG, some findings. The next evidence is troponins and CPKMB, and the next is imaging. So the next is echocardiography. What you can do is you can get a TMT done. Still you're not sure, you can get a stress echo done, or you can do myocardial perfusion imaging, so on and so forth. Still you are not convinced that the patient has an anginal pain or a non-anginal one, you go for a CT coronary angiography. If the patient wants a non-invasive one, you can go for an invasive coronary angiography, which can be a definitive one and a gold standard, and you can do intervention also at that same time. So you have made a diagnosis of ischemic heart disease. How? The patient had chest pain, you did an ECG, you did troponins, you did a TMT or a stress test, and you made a diagnosis. Okay, you did a coronary angiogram also. You made a diagnosis that my patient has a coronary artery disease or a ischemic heart disease. Now, how do you manage? If it is just a stable angina, that means the pain comes with the exertion and goes away when the patient is resting, then the initial things is blood pressure control, glucose control, weight loss, and stop smoking if they are smokers. Along with that, you give anti-anginals. Now, many people they consider nitrates as anti-anginals only. So the thing is that you have to understand that the anti-anginal is anything which either decreases the demand or increases the supply. So nitrates are related to increasing the supply, but priority should be to decrease the demand. So first line drugs are beta blockers, calcium channel blockers to decrease the heart rate or contraction.
Officer.
Second line drugs are the nitrates, that is vasodilators, nitrates, nicorandil, and then there are other drugs which are nowadays being projected and indicated to be used in angina. They are ivabradine and ranolazine. If the patient has suffered already an MI and the patient is having a post MI stable angina, then that means you will need to give them aspirin also. So that is called secondary prevention. Primary prevention is that you don't let the MI happen. So you give secondary prevention, aspirin you add on, high dose statins like atorvastatin 18, and remodeling of the heart with ACE inhibitors is mandatory. If the patient still has got chest pain and has not improved with the medical management, then you go for revascularization. Revascularization, the path is through coronary angiogram. So first you do coronary angiogram, either a CT coronary angio or a proper coronary angio. Once you find lesions there, you go forward with PCI. And if it is a triple vessel disease or a critical left main disease, then you will opt for coronary artery bypass grafting. This is for stable angina. Now coming for somebody who has an acute coronary syndrome. So ACS, we remember we defined it on the basis of unstable angina, non-STEMI and STEMI. So immediate management is MONAC. MONAC is morphine, oxygen, nitrates, aspirin and clopidogrel or ticagrelor. That is what is to be given. For non-STEMI or unstable angina, you need to do a risk stratification based on gray score. Once you've done that, you start the patient on dual antiplatelet. Nowadays, the crux is to give ticagrelor by all the recommendation societies. So add aspirin, but the next drug should be ticagrelor or like it used to be clopidogrel. And along with that, you start anticoagulation. Now, this is the difference in management. In stable angina, you never use anticoagulants, only antiplatelets, single antiplatelet, that is aspirin. But in case of unstable angina or non-STEMI, then you will start using anticoagulation along with dual antiplatelets. So aspirin, clopidogrel or ticagrelor plus heparin or fondaparinux. And there is no rush. You can do angiography within 72 hours. So there is no rush in non-STEMI. But in case of STEMI, primary PCI in STEMI is the gold standard, and it has to be conducted within 2 hours. That is the norm. That is the guidelines. And 90 minutes if door to needle time. Thrombolysis, if PCI is unavailable and in third world country like us, thrombolysis can also be done. After the PCI has been done, long-term management is aspirin plus either ticagrelor or clopidogrel for 12 months. Then single antiplatelet agent should be fine. Along with that, all other drugs like beta blockers, ACE inhibitors, statins, and diuretics if the critical muscle mass loss has happened and the patient has developed heart failure with reduced ejection fraction. What are the territories which can be used to identify the blood vessel involvement? So in ECG, if the lead V1 to V4, we will come to the ECGs, don't worry. Lead one, V1 to V4, LAD territory is the projected one, and the tissue involved is anterior wall. 2-3 AVF is classically RCA, and inferior wall is the territory involved. However, in left dominant circulation, it is the left circumflex which drops in a PDA. So it will become the left circumflex can also lead to 2-3 AVF changes. 1 AVL V5 V6 left circumflex, lateral wall involvement, and V7 to V9 PDA. Although V7 to V9 is not done routinely, but where you suspect that the patient may have a pure right heart infarction, then you need to get V7 to V9 done.